All right. So, good evening, everyone. We know that to treat glaucoma, the only thing that at this point in time we are comfortable treating is by reducing the intraocular pressure. And we definitely know that decreasing intraocular pressure is beneficial. So when you ask a question, how useful is reducing intraocular pressure in patients with normal tension glaucoma or patients with normal intraocular pressure? There is enough evidence to tell us that even in patients who have damage at lower intraocular pressure or at normal intraocular pressure control is the most important way of treating the glaucoma. So why do we even talk about this topic? What do we need to do beyond intraocular pressure? I'm sure each of us, and I definitely have a certain number of patients for whom, despite doing to the best of our abilities, despite decreasing the intraocular pressures, some of them tend to progress. And we are at a fix, not understanding what do we do with these patients. They are compliant, they come back to you whenever you ask them to, and everything else, as far as they are concerned, they're following your whatever you are advising them, but despite that, they tend to progress. So in case such a thing happens, what do we need to do and how do we evaluate our patients and what all do we need to understand? I will take you through a case that was a very interesting case that actually helped me to understand certain concept. This was about 7 to 8 years ago, a 64-year-old gentleman with normal tension glaucoma, who's been on treatment with PG analog since 3 years. His baseline intraocular pressures were not high though. And he doesn't have any systemic problems, and neither did he have any family history of glaucoma. His pachymetry was low normal and open angles on gonioscopy and very well controlled intraocular pressures with Xalatan. And his right eye definitely had a disc damage with corresponding field damage, and left eye was essentially normal at that point in time. So these are the fields. Over a period of time, he continued to progress despite being on very regular treatment and pressures always ranging less than 13 or 14. So what do we need to do? With the multiple interventions at that point in time, so left eye developed a cataract, he underwent a cataract surgery, and when he was progressing, despite treatment in the right eye, he underwent a combined surgery with mitomycin C. He had very good intraocular pressure control, almost close to 10 and 11 millimeters of mercury, but he continued to progress over the next 6 to 8 months. We started him on prostaglandin analogs again, and this is the trend that it showed over a period of 3 years. He continued to progress, and we were not sure because he was progressing. We added medications. We used to see him more frequently. Now he is pseudophakic in both eyes, so you can't think of any other cause. No pseudo exfoliation. We've ruled out everything that is possible. Every time he came back, he came with new disc hemorrhages, and the disc hemorrhage would disappear and a new NFL defect will develop in that area. And all the other investigations also showed the same changes. We did a diurnal intraocular pressure measurements. The pressures never went beyond 14 or 15 millimeters of mercury. Neither did he have a nocturnal dip in blood pressure. We did order investigations for him. All the systemic diseases we had ruled out, diabetes, hypertension, dyslipidemia, cardiovascular disease. He didn't have any history of blood loss, no other history of taking any additional treatment like steroids for any systemic problem. And his cardiac evaluation and carotid Dopplers were completely normal. Except that his son-in-law who had accompanied him gave a history that when I asked him, does he snore? He said, I'm not quite sure, but I can tell you that he does have a mild snoring. So the only thing that was left at that point in time was to do a sleep lab test and to rule out obstructive sleep apnea, and asked him to come back with the reports. And this was his report. He had an AHA index of 39.5, and he was advised by the pulmonologist to take continuous positive airway pressure. So to our surprise, once he started his treatment with the CPAP, his disc hemorrhages disappeared. And I was so happy to see him after 3 long years. I was struggling every time he visited, he had these hemorrhages. The first time I saw him after 3 months after starting CPAP, that is all his disc hemorrhages disappeared. And over a period of time, his visual fields also stabilized. So OSA, or obstructive sleep apnea, is becoming widely accepted as a risk factor for patients for glaucoma progression. So if you ask me the question, does it develop glaucoma, more number of patients with OSA, do they have glaucoma? I do not have an answer for that. There is controversial evidence in literature. But what we know is that if there are recurrent disc hemorrhages and if somebody is progressing, these are some of the investigations that one needs to do. What exactly happens with OSA is that there is intermittent upper airway obstruction during sleep, resulting in apnea and hypoxia. There could be other associated problems as well, apart from glaucoma worsening, that they also can have a non-ischemic optic neuropathy. They can develop venous occlusions as well. So AHI index is a way to understand the severity of sleep apnea syndrome. It's nothing but an apnea hypopnea index, which is an indication of a severity of sleep apnea. It's represented by a number. That means the number of apneic or hypopneic spells that this patient has per hour of sleep. So if the AHI is less than 5, is normal. Anything between 5 and 15 is mild sleep apnea. 16 to 30 is moderate, and more than 30 is severe. So this patient, according to this, had severe sleep apnea and was put on sleep app treatment. What do we know is that there are multiple vascular factors that are responsible for this damage that happens in these patients with sleep apnea. So there is a vascular dysregulation, possibly an autonomic dysfunction, possibly reperfusion oxidative stress that happens, and all of these cause the multiple disc hemorrhages that you see and vascular type of a pathology, but they also can have mechanical factors because of the positive pressure that they have, or the increase in resistance that they have while breathing as well. So how do we, other than these investigations that I told you, the commonest things that we miss, a commonest differential diagnosis for an NTG who is progressing is a missed angle closure glaucoma. This is not at all uncommon to us, and several of us actually keep re-diagnosing these patients as having an occludable angle or angle closure glaucoma. Sometimes a steroid use is something that we do not ask for a history. They may not tell you. A subtle pseudo-exfoliation, which may not be picked up until we dilate the patient, is also one more reason why they can have spikes in intraocular pressure. That could be responsible for this. And of course, there could be some other neurological causes which we may be missing as well. History is extremely important for us to understand if there are any other lifestyle changes that are actually causing this problem, like excess alcohol intake or excess water intake for that matter. Exercise certain types of exercises, and the sleep position, although this is controversial, but there are certain studies which have shown that the side that they sleep on, or if they are using a pillow to elevate their head to a greater level, possibly also can cause some amount of decreased vascular supply to the brain and of course the eye, and they can cause progression in glaucoma. But these are things that are not something that we really evaluate, and of course systemic evaluation is very, very important. Another question that is commonly asked is, do we neuroimage these patients who are progressing? This is not uncommon. Some of these patients actually come back with MRI reports and they say even the scan is also normal. We still don't know why the glaucoma is progressing. So what are the recommendations for us to do neuroimaging for these patients? Young patients, if they have a unilateral disease, and if you have clinical findings which are not correlating with the changes that you see in the visual field, and atypical visual field defects which do not fit into the defects that typical of glaucoma, and of course the color deficiency and acute decrease in vision. These are some of the findings that will possibly guide you to do a neuroimaging. Otherwise, it's not a routine to do it for all patients with progression or all patients with normal tension glaucoma. So this is another interesting concept of excess water drinking or excess alcohol for that matter. Whatever, any fluid that is taken in excess can actually raise the intraocular pressure. This is, again, we have read a lot about it, but then it really doesn't strike you until you come across a patient who has a problem like that. I had a gentleman, every third time or fourth time he comes, his pressures will be very high. Otherwise, they are usually between 12 and 15. Sometimes his pressures will shoot up to 30s and 35. That would be the maximum. And I mean, I was very surprised, and he is quite reliable with his medications. His mother is a known glaucoma patient, so he knows the seriousness of the disease. So he actually one day came and asked me, "Doctor, is there a relationship between alcohol intake and my intraocular pressure going up?" I said, "I have no idea, but yes, it may cause." So he says, "Every time I attend a party the previous night and I come to see you the next day, my pressures seem to be high. This I've noticed for the past 2 to 3 times." And that is when it really hits you that these are things that are not just read in books, but this can happen to even our own patients. And whenever there is something unusual happening, I think we need to pause, go back and ask them what other things could have happened that has contributed to this change. So even water, excessively drinking water, let's say 1 liter, 2 liters of water, some of them do that excess water drinking in the mornings, especially when they wake up and after they do some exercise. Some people have the habit of doing this, and for glaucoma patients, it may not be a wise thing to do. They can definitely take water, but then stagger it and take it in limited amounts. So what does that excess water drinking do? It apparently increases the choroidal blood flow and the volume, and of course, increase in the fluid outflow, fluid inflow, as well as raise in intraocular pressure. So some exercises, this is a common question that patients ask, does exercise affect intraocular pressure? Not general exercises. General exercise is good for health. So apart from that, there are certain asanas like Sirsasana, which a study from Shankar Nethralaya has shown that there could be a twofold increase in the baseline intraocular pressure in a head down position. That is because of the excess blood flow. So any position of your head that is lower than your heart can increase the intraocular pressure as well. So this again, for somebody who's progressing, this may matter, but otherwise, as such, these asanas may not be detrimental to everyone. So can glaucoma progress when intraocular pressure is well controlled? This is a question with which we started. So I would just like to summarize to tell you that yes, it does. And we do come across these patients. And what all do we need to evaluate in these patients who progress? I think we need to think beyond the intraocular pressure. A good clinical evaluation of the eye is extremely important to rule out the other conditions like angle closure, pseudoexfoliation, or any other condition that is actually causing any other secondary cause that is causing a rise in intraocular pressure. Take appropriate history, appropriate systemic evaluation and investigations that are necessary. Do not over-investigate them. But then I think a clinical judgment is necessary for us to evaluate. Otherwise, a list of investigations that we give is not necessary. And most often when you do an NTG, when we give an NTG form and ask for investigations, several of them come negative. So if we have a patient who's progressing despite a normal intraocular pressure, always suspect insufficient intraocular pressure control. That's the first thing. And sometimes I also ask this patient, so they may have used the medications very well before they came to see you, but it's possible that in between they have been skipping their medications. This is again not uncommon at all. And in between, whether they have stopped using these medications, timing of using medications, the way they apply medications, all these are extremely important. Apart from that, diurnal fluctuations in intraocular pressure is something that we always have to remember. Missed angle closure is not uncommon at all. Systemic factors like high blood pressure or dip in nighttime blood pressure, a nocturnal dip. Apart from this, again, using antihypertensives at nighttime, which again can relate to decrease in the blood pressure at night. Sleep apnea is a very, very important factor. This is something that is not commonly thought of. But again, like I said, when we see fresh disc hemorrhages happening, this is one investigation that we definitely have to do. In fact, if I can give you an example of if I suspect a patient of as having sleep apnea and ask for investigation, until now, from what I have seen, except for 2 patients among the 50 or 60 that I have sent, all of them have had moderate to severe obstructive sleep apnea. So it's not uncommon at all. And it's just that we need to suspect and do it in appropriate patients. And of course, the abnormal things like excess water drinking and certain types of exercises is something that when you go back and ask them the history or spend a little time with them, and I think they will be able to give us these additional information. So that will help us to treat the patients better. All right. Thank you. And I would like to take questions.
Dr. Srisha, there is one question. Do you do BP Holter recording as a routine for patients of normal pressure glaucoma?
No, we don't do that. So what we do is we do a 24-hour intraocular pressure diurnal. That means we admit the patient. We have the facility, fortunately, at the institute. We check the pressure, intraocular pressure every 3 hourly. And every time we check the intraocular pressure, we also take the blood pressure for the patients. You know, apart from the history of antihypertensives and what medications they're using, of course, beta blockers you would want to avoid, especially at nighttime.
Yeah, I saw that you had taken your diurnal variation. It was taken at 2 a.m. also, which is probably most of us and the hospital is probably not possible. And
Yes.
if I remember in RP center days also, whenever we used to admit patient for diurnal variation for glaucoma suspects, used to start from morning 5 o'clock, 5, 8, and then 12 o'clock, and similarly in the evening. So that is something which is probably most of the places it's not possible. And people are talking about the day diurnal, which is a highly compromised diurnal test.